Welcome to Easy Endo Prep's Endo in a Bite. I'm Dr. Sumbul Beg, and this podcast is your quick study snack designed for busy endocrinologists who want fast, board-relevant content that actually sticks. Whether you are preparing for initial certification, recertifying, completing the LKA, or simply staying sharp in clinic, this podcast is built for you. If you want my full board-focused system, visit easendoprep.com where you can enroll in the complete Easy Endo Prep Board Review course or start a free trial. Today's bite focuses on cardiovascular risk assessment and lipid biomarkers. Let's start with a common situation in clinic. You are seeing a patient for primary prevention. They are 52 years old. Their low-density lipoprotein cholesterol is elevated. They have several cardiovascular risk factors, but they have never had a cardiovascular event, and so the question becomes simple. Do they need lipid-lowering therapy? And before answering that question, we first need to estimate their cardiovascular risk. For many years, clinicians relied on the pooled cohorts equation. That risk calculator was introduced in 2013. It estimates the 10-year risk of atherosclerotic cardiovascular disease. But over time, an important limitation became clear. The pooled cohorts equation tends to overestimate cardiovascular risk in modern populations. And there is a good reason for that. Risk factor management has improved. Statin therapy is more common. Blood pressure control is better than it was in earlier decades, so the background risk of cardiovascular disease has changed. Because of this, the American Heart Association introduced a new risk model in 2023. This model is called the PREVENT calculator. I have included the link to the PREVENT calculator in the PDF that is sent to your inbox when you sign up for the newsletter. PREVENT stands for Predicting Risk of Cardiovascular Disease Events. The model was developed using newer data from a larger and more diverse patient population. The goal was to provide more accurate risk estimates that better reflect current patterns of disease and treatment. But the update does more than just recalibrate the numbers. It also introduces a broader conceptual framework called cardiovascular kidney metabolic syndrome. This framework recognizes that cardiovascular disease, kidney disease, and metabolic dysfunction are deeply interconnected. Using the PREVENT equations, clinicians can calculate both 10-year and 30-year risk estimates of total cardiovascular disease. Total cardiovascular disease in this model includes both cardiovascular disease and heart failure. The calculator is designed for adults between 30 and 79 years old who do not already have established cardiovascular disease. Based on the estimated risk and associated risk factors, patients can be categorized into cardiovascular kidney metabolic stages, ranging from stage 0 to stage 4. This staging system helps guide treatment strategies aimed at reducing long-term cardiometabolic risk. Now, one of the most important innovations in the PREVENT model is the integration of kidney function into cardiovascular risk prediction. This is important because patients with chronic kidney disease have a substantially higher risk of cardiovascular events. However, earlier models such as the pooled cohorts equation did not directly incorporate kidney function into risk prediction. The PREVENT model addresses this gap. Estimated glomerular filtration rate is included as a predictor in the base equation. Additional models can also incorporate the urinary albumin to creatinine ratio to further refine risk estimates. And kidney function can significantly influence predicted cardiovascular risk. For example, if the estimated glomerular filtration rate is greater than 60 milliliters per minute and there is no moderately increased albuminuria, the estimated 10-year cardiovascular risk is typically less than 2%. However, if the estimated glomerular filtration rate falls between 30 and 60 milliliters per minute and moderately increased albuminuria is present, roughly 100 to 200 milligrams per gram of creatinine, the estimated risk rises into the intermediate range of about 7.5% to 20%. And if the estimated glomerular filtration rate drops below 30 milliliters per minute, the estimated 10-year cardiovascular risk becomes high, exceeding 20%. Another important feature of the PREVENT model is that kidney function is treated as a continuous variable. Because of that, kidney function should generally be included whenever cardiovascular risk is calculated. The PREVENT model also reflects evolving thinking around race and social determinants of health. Earlier cardiovascular risk equations included race directly in the calculation. The PREVENT model removes race from the equation. The reasoning is that disparities in cardiovascular disease are believed to arise from structural inequities and social determinants of health rather than biological race. To address this issue, the PREVENT framework includes an optional add-on variable called the Social Deprivation Index. This index is measured at the zip code level and attempts to capture neighborhood-level social disadvantage. However, this approach still has limitations. Social determinants of health are not always consistently captured in clinical datasets, and the model may underestimate risk in certain populations, particularly South Asian individuals. So clinical judgment remains essential when interpreting these estimates. Once baseline risk has been estimated using the PREVENT calculator, additional tools may help refine risk assessment in certain patients. One such tool is coronary artery calcium scoring. Coronary artery calcium scoring uses a CT scan to detect calcified plaque in the coronary arteries. This allows clinicians to identify subclinical atherosclerosis. In patients with intermediate predicted risk, a calcium score of 0 can help reclassify them as low risk. But there is an important limitation. Coronary calcium scoring should not be used to rule out disease in younger patients who already have high-risk features. For example, patients with diabetes, a history of cigarette smoking, genetic hyperlipidemia, or a strong family history of premature cardiovascular disease. Younger individuals may develop soft, non-calcified plaque that is not detected by calcium scoring. In that situation, a calcium score of 0 does not have the same reassuring negative predictive value that it has in older individuals. In some patients, additional lipid biomarkers can help refine cardiovascular risk. Two of the most commonly discussed markers are ApoB and lipoprotein A. These markers are sometimes called risk-enhancing factors because they can reveal hidden cardiovascular risk that is not always captured by the standard lipid panel. Let's start with ApoB. ApoB reflects the number of circulating lipoprotein particles that contribute to plaque buildup in the arteries. Every one of these particles carries exactly one molecule of ApoB. So when we measure ApoB, we are essentially measuring the total number of plaque-forming lipoprotein particles in the bloodstream. And that distinction is important. Traditional low-density lipoprotein cholesterol measures the amount of cholesterol inside those particles. But it does not tell us how many particles are actually circulating. In many patients, those numbers move together, but in certain metabolic conditions, they can become discordant. This is especially common in patients with elevated triglycerides. When triglycerides are high, the low-density lipoprotein cholesterol level may appear relatively normal, but the number of circulating lipoprotein particles may actually be much higher, so the cholesterol measurement alone may underestimate the true burden of particles that can contribute to plaque formation. In that situation, measuring ApoB provides a better estimate of the total particle burden. ApoB can also be useful in patients with metabolic syndrome, obesity, insulin resistance, or type 2 diabetes. These patients often have many small, dense, low-density lipoprotein particles. The cholesterol level may look acceptable, but the number of particles may still be elevated, so ApoB can help identify patients who may have residual cardiovascular risk despite apparently reasonable cholesterol levels. In terms of interpretation, a level above about 130 milligrams per deciliter is generally considered elevated and associated with increased cardiovascular risk. For patients at higher cardiovascular risk, many clinicians aim for an ApoB level below 80. And for patients at very high risk, targets below 65 are often used. However, when triglycerides and high-density lipoprotein cholesterol levels are normal, Measuring ApoB usually adds little additional information. In those situations, the standard lipid panel often reflects the particle burden fairly well. Now let's talk about lipoprotein A. Lipoprotein A is a genetically determined lipoprotein particle that behaves differently from typical low-density lipoprotein. Levels are largely inherited and remain stable throughout life. Diet and lifestyle changes have very little impact on this marker. Lipoprotein A is considered a strong independent risk factor for cardiovascular disease. It promotes plaque formation in the arteries, increases vascular inflammation, and may also increase the risk of blood clot formation. Because of this, many guidelines recommend measuring lipoprotein A at least once during adulthood. But there are certain situations where the test becomes particularly helpful. For example, patients with suspected familial hypercholesterolemia, patients with a personal history of premature cardiovascular disease, patients with a strong family history of early cardiovascular events, or patients who continue to develop cardiovascular disease despite well-controlled low-density lipoprotein cholesterol levels. In these situations, an elevated lipoprotein A level may help explain the excess cardiovascular risk. In terms of interpretation, a level above 50 milligrams per deciliter is generally considered elevated. Higher levels are associated with substantially increased lifetime cardiovascular risk. Outside of these specific scenarios, measuring lipoprotein A may not significantly change clinical management. So the key idea is this: ApoB helps estimate the number of plaque-forming lipoprotein particles, especially in patients with elevated triglycerides or metabolic disease. Lipoprotein A helps identify inherited cardiovascular risk, particularly in patients with premature disease or a strong family history. Used in the right clinical context, these biomarkers can uncover cardiovascular risk that a standard lipid panel may miss. So the key takeaway is this: predicting cardiovascular disease risk is a critical first step in deciding which patients should begin lipid-lowering therapy. The PREVENT calculator represents an important advance because it uses contemporary data, incorporates kidney function into risk prediction, and introduces the broader concept of cardiovascular kidney metabolic syndrome. When combined with tools such as coronary artery, calcium scoring, and selected lipid biomarkers, clinicians can refine cardiovascular risk estimates even further, and that helps identify the patients who will benefit most from preventive therapy, ideally long before cardiovascular disease becomes clinically apparent. That wraps up this episode on cardiovascular risk assessment and lipid biomarkers. I actually chose this topic because I recently bought the newly released ESAP 2026 book, and the PREVENT calculator came up in one of the questions. So I figured it was a good opportunity to review it together. If you missed anything, don't worry, I've taken all the notes for you. You can get a clean summary with headings and bullets delivered straight to your inbox. Just head over to www.easyendoprep.com and sign up for the newsletter. Until next Monday, keep tuning in and we will learn one bite at a time.